Thank you very much. So it's really what I'm going to talk about tonight. I've entitled Quality Improvement for Health and Well-Being, System Strengthening through University Partnerships. Because one of the greatest opportunities that I've had is to really be part of the Global Health Institute at UW-Madison and think about what the role of higher education can be in change. And I think when a lot of the efforts to increase the role and involve higher education in bilateral assistance in particular, we had the idea that higher education institutions would do similar things to bilateral agencies and get new sources of grants, and that's how that would work. And after spending the time, working in development and then having the opportunity to come to UW-Madison and begin to understand higher education, I think there's other ways of thinking about that relationship that might be more complementary and really kind of having different roles rather than getting into playing the same role. And I've kind of been thinking about with others for a while, and so that was what gave the impetus to share this history tonight. So I want to say a couple of things about the Summer Leadership Institute. We've had the Summer Leadership Institute, which a lot of people associate with, what the QI program here at Madison is. And there's a number of people in the audience here who've played vital roles in that. Sweta Shrestha, who's a public health specialist, trained here at Wisconsin, has been involved from the very beginning as an instructor, as a leader of one of our national programs, and she's provided technical assistance in quite a few of the countries. Betsy Taglin has helped to support the offering of that program in many ways, as have Monet Haskins and Kim Santiago, and many others on our global health staff. I don't know if Kayla Benke's here, but it's a real team effort to put that on. And so I just want to mention that. Doing the whole thing we do during the semester in the summer for people from other places, it's not trivial. So it makes us appreciate the task of educating 20,000 students between September and June when we do a program for about 30 in July or August. So I guess one thing, if I left you with one thing about quality that I would say is that for me, quality is a compass for global health, and it allows us to link local, the personal, the good life, all the things that we imagine for an intersectoral approach to health and development. Really, quality of well-being captures that. And the thing about a compass and about true north is you try to get there knowing you never will. So there's a certain kind of person who does quality. People who are willing to try to get there knowing they'll never completely get there, but they'll get closer. They'll either make incremental changes that really matter, or they'll make transformative changes that make change for a lot of people. And both of those kinds of outcomes have happened in our quality improvement work at UW-Madison. So I'm going to talk today about our Leadership Institute. I'm going to talk about how my understanding of how QI methods have evolved over the years. I think it's very interesting to see how some of the basics are the same, and how it's evolved and how it can evolve further. I'm going to talk about how we approach leadership, teamwork, and culture of quality, which is more than half of change making in this space. And I'm going to talk a little bit about what publishing means in this area as well. Documenting and publishing QI is different than documenting and publishing the results of randomly controlled trials, and it's important to understand how those complement each other. It's not so much a hierarchy as they're very complementary tasks in my view. I want to talk about what it means to scale up quality, because we are a big university. We should be doing big things, and everything we do should have scale. And so how can we scale up QI, help people do that at the national level, and even within large healthcare systems? It's a really big deal to scale up a small change in a big system. And then there are some big ideas that we always talk about in global health, and it's useful to go over making the QI linkage here. So what is the Leadership Institute? Well, I prepared this presentation for a briefing recently at USAID. And the first thing I wanted them to do is to understand there is a difference when you come to Madison versus going to sending people to training opportunities at other wonderful global health institutions. However, you don't usually arrive to this, and you don't usually get on a plane at 5 p.m. and by 8:30 you can be having dinner by the lake, and you won't need a car or a taxi much. You'll walk to class along the lake shore, and there's a beautiful campus and meals and friends, and people really have the time to sit down and mentor people. So we have a unique character to our QI Institute. There are similar institutes held at all the leading public health schools, at Johns Hopkins, at Harvard, at University of Washington, and I've had the privilege of teaching in some of those over time, and they're all great, but we just have a different quality here that's worth noting at Madison in terms of really mentoring and making sure people make a change in their career, and they have almost like a retreat reflective experience as well as getting like a mini course. And so I'll stand by that. We are special, and in some ways we're doing this, I think, in a very empowering way. So we've had about 120 leaders from 14 countries who've participated since 2011, and this has allowed us to strengthen existing partnerships. We have an amazing health science community here, and there are leaders from medicine, pharmacy, nursing, veterinary medicine, PT, social work. Most of these fields have brought partners here, and they've used the QI Institute to strengthen an existing partnership that they have ongoing. So much of the success I'll describe will be coattails of great work that's already being done in these different areas at UW-Madison. We have a joint learning philosophy, which means we try and even not to say it's a class. It's not a training. We're sharing what we know. We don't stand up in front of these leaders who are facing really, really difficult challenges pretending that we know how to solve their problems. What we're saying is we know you're leaders. That's why you're here, and we want to work with you with whatever's on your desk at home that is really difficult. We'll do some work here that can help you make change there, and hopefully you'll learn from each other. It's not that we don't have things to share, but it's a pretty small part of what happens. They start to really relate with each other, learn from each other, and when people are asked to stand up and say what they've learned at leaders, they really own that. And what we noticed after about 3 years is we had people from previous years getting up and saying what they'd done and how they were leading, and that function that happens in a joint learning community when you really walk the walk on this, people start taking those former trainees as role models. And you have Sweta saying, I started a national program. It's pretty mean of me to put Sweta up there, because then everybody wants to do what she's done, and they're trying to start national programs and do big things. And so letting people share their stories about big things they've done, it gives people a lot of role models in each other and this idea that we're a community, and they have been staying in touch, which is really nice. We want to leverage the assets of higher education. And again, when I'm speaking in that bilateral assistance space, there's a resistance to bring people here. They're like, why would you bring them here? The work is there. Well, just like us, when people from the countries we work with get to travel and see how things are in another space, it's very stimulating. They get ideas. They start to get a comparative perspective that allows them to learn and grow. So when the travel part is only in one way, we get to go there, we're not getting people to have that rich experience that we're having by comparative learning. And so I remember it was Dr. Harvey Feinberg was here. He was giving a speech in this room, and we asked him about global health. What can global health mean in a state university where our main goal is to train people to care for people in the street? And he pondered a moment and said, comparison illuminates. And when someone is in a rural community in Wisconsin and they're seeing a fever that seems a little bit different, we want them to have other comparative experiences to bring to be able to suspect that it might be malaria because this person took a certain trip, or it might be, some other thing. So the idea that comparison illuminates was illuminating for me. And I thought about those two words a lot, because this comparative systems learning is huge, and our leaders who do so much with the partners do come back with lessons for their own practice. So it really does make things better here to make things better there. Building networks, I believe in that. You can tell, and evaluation. So we have evaluated our programs in different ways, and now we're doing a really comprehensive, more storytelling thing where we can look longitudinally at what happened, in some of the earlier programs. This is a color-coded list of the countries that have participated in the Institute, and I just had this bright idea of the color coding this morning. Because I'd like to have something new for SWETA, but also because I thought this would be illustrative. So all of the countries have been represented to some degree in our QI Institute. Someone has said, I'm from this country, I'm working there, I'm applying this there. But the countries in red are places where we have also gone to the field to do field-based training. So our QI program is actually quite global. We've done training, if you count the U.S., in about 6 countries. And then the green ones are places where we have people who have taken, and actually some of the red ones are also green, but I didn't know how to stripe them. I'll do that for next time. But these are places where there's been some intern or graduate of our certificate programs or graduate of this program who is planning to or has done field work in those places. So this idea that the Institute is a course, a network, something that can be offered in different places and where there's follow-on technical assistance, it's what we're aspiring to for the future, to be more intentional. But when we look back at what we've done, just with the way higher ed works, we've really already done, we've done quite a bit of that. So the program includes sharing successes and experiences. Everybody has to have a voice as a leader. Exposure to QI methods. We focus on leadership, and I'll tell you what we do. We focus on interprofessional skills, and I think we were among the first QI programs to incorporate what's happening in the interprofessional education and collaboration space. And partly because UW is really on top of that and doing it well. I went to a continuing ed thing. Again, it happened to be in this room of the medical school, and I realized the potential for integrating it into the global space. And really, people aren't really talking about this that much in the other QI programs. It hasn't kind of hit yet, and yet it's such a useful tool, and it's even more useful globally because of the kind of task shifting that can happen just because the regulatory environment is different. So I think the interprofessional aspect could be a lot stronger even than it is, but we do a fairly good job. And then we also have a lecture series from clinical experts, because what we heard was it's not just about QI methods. We also want to learn about the state of the art in different fields. We're in the periphery in some sense, when we're out there in rural Ethiopia, and to hear from a palliative care expert, or to hear from, there he is back there, Jim Cleary's in the back, or to hear from Guillermo Tefera talk about, surgery and his role in global surgery, to hear from Cynthia Anderson talk about family planning frontiers with her work, and to hear about health impact assessment from Jonathan Patz, or the comparison between local and international vaccination programs and the challenges that are similar and different from Dr. Jim Conway. Those are all things that are very exciting clinically for people. And without that, it's not that interesting, because even though it's important, it's all about process if you don't have those really key clinical things. This year we also introduced, Dr. Chris Olson introduced this One Health framework, and a lot of them had not heard about that before. And it's their world. It's very natural for them to see, once you point it out, that we should have all along been thinking about the relationship between the health of humans and the health of animals. So, and it's very exciting to create a platform where our leaders can share their expertise in that way. The comparative systems approach, I can't say enough about how important I think this is, but we can do more of helping people to understand their own systems better, and then maybe our system. And by crosswalking two systems and the strengths and weaknesses of both, you can identify lessons and opportunities for improvement for both. And if we can prove that that happens routinely and is the norm rather than the exception, we can open up new ways of doing health and development, which I think is going to be necessary in this era as bilateral assistance dries up, as we look for more efficient ways to provide health care in the U.S. We need to be learning from lower resource settings. Middle income countries are doing doing a lot of things a lot better than we are. Not everything, but the areas where we tend to perform better are areas where we have the equivalent of universal coverage, like for older citizens who have Medicare and some of those more comprehensive programs, we tend to be the best in the world. But in the other spaces, we're not. And there's big efficiency problems in terms of how much it costs. So we have a lot to learn from others, and this gives us a great context to do that in. And they also develop and present a QI project. I am no fool when it comes to using sticks as well as carrots. And when they come in, they hear that they come in on Monday, and they know that on Friday, and usually it is in this room, so they find out that they're going to be here presenting before their peers and some UW faculty what their projects are. So everybody's motivated because it's a great challenge and exciting to give a public lecture, but it's also, I think, for most of us, something that makes you stop and work hard. So that's kind of part of, and we really emphasize the relationship building and the social aspects of it too, by creating opportunities for shared meals and social things and so on. Another nice thing about the way this program works is when we do follow-on work, like the follow-on work that we did in Black Lion Hospital, we're arriving to the field to people who know us, who know what we have to offer. Usually they've had a chance to choose, who the team is. So when Sweta and I and also Roman Idiko, who was a great colleague in this Ethiopia project and is finishing her doctoral studies in QI in Colorado right now, but she's a native of Ethiopia and also a Wisconsin girl and a woman now, and so she got to participate in this project. But they've said who they want the team to be, and we come there and they know our place and they know our world, and it just means that the training that we offer in the field is more effective rather than this drop-in thing. So in Black Lion Hospital, this happened in the context of a wonderful partnership that was led by Girma Tefera, and they developed the capacity. They developed a residency program, but we trained them in just basics of QI. And over time, a number of QI projects were successful. They developed a triage system. It was painful to do for all kinds of reasons, but once they figured out what worked in the Black Lion Hospital, the most complex setting in the city, they were able to train all the other urban hospitals and how they were doing it with their new triage form and their systems. And, if we can do it, you can do it. So that's a pretty important thing. Do we do the longitudinal study to measure changes in mortality? There's a whole bunch of reasons why that's hard to do, and no, we didn't. A, we didn't have the funding to do it well. B, a triage system is what creates the record that would allow you to detect the difference. There was no triage, therefore the baseline is not clear, right? So it's difficult to do. But am I confident, because of what I know triage is and does, that we've saved lives with a huge multiplier effect through this triage thing? Yeah, I'm confident. I don't really need to do the longitudinal study because there were anecdotal studies, but it is difficult, even with a lot of resources, because you're changing the data quality while you're changing performance. It's difficult to do this with a kind of pre-post model or a controlled design like we would talk about, and that's where we'll talk more about how to document QI. Those kinds of problems come up all the time with documenting QI. Yes, it is. Yeah, it's the big referral hospital. So everybody's trained there. Everybody goes there. Some people want to tear it down. Other people want to love it up. It's just an institution of public education and medical education in Ethiopia. So it's an honor to work there. I love this place and want to make it stronger with partners. They also looked at infection compliance with infection prevention, and this is Dr. Aklilu Azaz, and he led this. He'd been working on this for years, and the combination of how to work in teams and how to create follow-through in the QI methods, he felt really made a difference for him. So he became a QI zealot. And one of his main qualities as a leader was to show people through demonstration before you start talking about it. People have heard the talk enough, and I'm going to do it, and then I'm going to tell them. He'd always say that, and he was deeply respected by the teams. They made other improvements that are listed here, and Dr. Aklilu established an ongoing quality improvement committee in the emergency department that runs on its own now. It still goes on today. And they did share that in the hospital, and they can scale within the hospital as they need. When they say, do you want to come and do more training? I say, I want to come. I'd like to do more work, but no, not more QI training. You have plenty of capability to do QI training now. It would be silly for me to come all that way to do something that you know as well or better than we do. So we really have institutionalized the training capacity building there. Here is the Duli Keel Hospital program led by Sweta Shrestha and Dr. Biraj Karmacharya, and others. Sweta and the team have brought about 8 people here over time to learn some QI skills, and the program has evolved with projects. It's also, the Duli Keel Hospital is in a position to lead national because they have university affiliations, and they asked us to join in on a NHLBI grant that they wrote that they were successful in getting, and we're responsible for helping them do the QI portion of that. So there's a lot more, I think, that will be happening in this space, but this is a different approach because they're partly because of the networks that Sweta had built over the years with doing some QI, orientation workshops when she was there with our students, and then being able to follow up the next year. There's now kind of a fomenting a national momentum to develop the QI, program there. So that I have high hopes will be really successful, and it's very, very nice to be in the space of the working with NHLBI as well. No, Duli Keel, it's a little more rural, but it is a lot of people are walking. It supports a great network of rural clinics as well. So it's a system. So we also have been working in the Tibetan children's villages, and this project, Dr. Zorba Pastor was involved for years, and it's a great example of how it works when we take people who are doing great work at UW-Madison and offer the QI Institute to help them grow their work. Dr. Pastor brought people here. They came with the idea of doing an electronic medical record, and there's kind of 2 stories I like to tell about this project. One is how when I talk about the methods, about how important it is to envision quality. So we were emphasizing that with this group. What does quality look like? What does it really mean? What does it mean to be a quality of care provider? And they fell out of love with their medical record project because they realized they could do that anytime, but you've come all the way to the U.S. to learn some new things. And they said, when we're really honest with ourselves, we know that there are live cases of TB in the children's villages, and we're responsible, and they're not being treated. And that is not quality. And this was a confessional moment for them where they just said, we are abandoning the other project. We'll do it sometime, but we want to do this. And so what happened then was they articulated a project that was really sound about how they would do this case founding. And Dr. Pastor connected with Dr. Richard Chazen, who's a global TB expert at Hopkins, and Dr. Kunchak Dorji, who was a Tibetan physician who was finishing his doctoral work, and they were kind of working in this space. And so they were improving quality of care and looking at clinical aspects, so strengthening the hospital. The hospital was well equipped to do the care. So they got involved in helping out with the case finding, and the group was able to get, I think it was like a $200,000 grant to implement this program. And they invited me to come to do some follow-up on site, and when I went there, they were telling the story, and they said, well, we were supposed to, I always encourage them not to let the timeline be too ambitious, because you're going to get back, you're going to have a lot of work. I don't want you to get discouraged that you're not meeting your deadlines. So give yourself enough time to do the project. So when they got back, I think they were supposed to start in January, but they got back in September, and they were like, we didn't really want to wait till January. By January, we had already diagnosed like 10 cases and, gotten them treated. So it was really very exciting then to go back and visit and see, to walk in those children's villages and see that they were admitting that they had the problem and stamping it out. The Dalai Lama is involved also in communicating the importance of this. It's, part of why it happens in the children's villages, it has to do with underlying vulnerabilities of the Tibetan population because of the socio-ecological conditions they face. So while there are some things about the conditions of the children's villages that could be changed, they're more like boarding schools. They're very happy places to the most part, and it's just that you have this vulnerable population and you have to pay attention. Also, the monasteries and nunneries are also places where there's more TB, and they're also looking at working there. So that was a very an example of something sometimes just doing something small well, it finds its scale, and that will be an example really for all of India, because these rates in the residential settings, in the children's villages, and in prisons and other kinds of settings, they're higher than just about anything else in India. So there's a lot that will be learned there. Leaders have gone on to replicate the course. I will get emails saying, can you send me the PowerPoints, or I translated these into Creole, or things like that. So we tell them that a lot of QI programs will want to be copywriting or branding, and we don't. Everything that we do, they get a disc with everything on it, and it's all in editable form so that they can make it their own, and if they have the courage, they can go off and do their own course. And some have done that, and I'll tell you about one in a minute. Some of them have gone to do advanced study in QI. We've had a number of people get small fellowships or even larger things, because it gives them that first step to getting into those kinds of selective programs. So again, some of the other programs, which I also think are wonderful, will get a cadre of people who are already established in kind of the bilateral assistance world. And we tend to get people who are working for ministries of health, who are not so often their first trip to the United States, not always, but probably half. It could be their first trip to the United States. So they're getting into a space that is new, and we're getting down to a space that is really important. We really don't want to only be impacting the development infrastructure. We want to get into the ministries of health that people are saying, we can do this. And in fact, one QI project that I did with a team, but anyway, I'm saying because I was asked to sit down we did this QI for orphans and vulnerable children. It was based on some work that I had done and some work that Nancy Kendall from our School of Education had done. And we did it with the Ethiopian colleagues, but we're very careful to leave it in their hands, to finish as they like. We didn't stamp our name all over it and all that, because that's not how this type of work is done. And then someone who thought it was successful had me sitting at a table with a leader from Tanzania, and was saying, you want to talk to this person from Wisconsin because they've done this quality improvement work with orphans and vulnerable children. And he said, that would be fine, but I'm really most interested in the Ethiopian model, And partly, he's right. He should be more interested in African models. And the fact that we had been a partner in that, it made me proud that, that kind of sharing was occurring. So I've mentioned already how we are doing follow-up field support. We want to do more of that and figure out ways. We don't really have a business model for all of this yet. I think we can, but right now it's nice the way we do it, because it has this, very organic, emergent, people who care, make it happen thing. But it would be nice to have a fund where we could bring people, and we could, bring people who couldn't do this otherwise here, and where we could get our faculty who are willing to go and do the follow-up work there, to do this kind of field support. But we're doing well and managing with our big hearts and bad business model. So they do stay connected with each other in UW. I'm going to just tell a story. This is the kind of thing that happens, and this was great because I was kind of tired, honestly, and we were about to do the QI Institute, and this popped into my email. Dr. Ayelu Ayele wrote, and it was about, I think it was 4 years after he'd come here, and he had been the most, low maintenance, grateful of our group that year in terms of the quality of his work and the way he approached it. And he was working with the Elmhurst Hospital Center, and they were just fantastic 20 partners, and I had so much respect. In fact, they participated in a QI training with their partners in Addis that we were at, and they came up afterwards and said, this is great because you're teaching them a language that our partners in our hospital use. We were using the Focus PDCA model because many of the hospitals, including ours here, use that. And so they found a common language. Anyway, he wrote to say that with iterative cycles of quality improvement, he'd reduce the neonatal mortality rate at the Deborah Berhan Hospital from 36% to 12%. And he was really crediting the QI training as critical to the success, and that it allowed him to to leverage other assets. And he went on to describe how this is one of the children that was among the lowest birth rate they had ever delivered, and the mother brought this child at 3 years old to meet the healthcare staff because the parents had thought it was such a miracle, and she remembered, and I forgot how many miles she traveled to go and say hi to them and like, look at my kid, you know. So that was pretty great to feel that like the Wisconsin idea had that kind of reach, and I was glad I was tired and glad we were doing the thing again. What was interesting about this case, as I got a little more information, is that he participated in our course and he had found a template that we had given, and he'd found an example from one of the Addis projects. And when he saw that example written up, it really gave him a vision of how to follow through. So some of our projects honestly had better follow through in the field than others, like the one that Roman Idiko worked on. Obviously, we had a summer intern doing it with rigor, walking the walk. So he got a hold of some of those, and it allowed him to do an incredible job of documenting to QI. All the different cycles, exactly kind of what worked, what didn't, and he has in bold things that weren't achieved, that were supposed to be achieved. And so really, it becomes a case study for others. And so it was a validation of the motivation that happens, the first of all, the talent of an individual who probably would take advantage of anything this well, but also by having, methods and templates and steps and formats, it's just not trivial. It makes it easier for busy people to follow through, and the value of case examples as well. This was in rural Ethiopia. Evolving QI concepts and methods. Our QI program is not all of QI. There's a lot of wonderful things that need to happen in QI that we don't do. We don't really do accreditation. We don't focus on collaboratives, which is really a state-of-the-art way of talking about quality, mainly because most of our trainees are isolated enough and they don't really have the resources to form these multi-institutional collaboratives. So that's a direction we'll go in the future. But we really focus on internal team problem solving. How do you define quality? How do you measure it? And how do you improve it? It's a very simple model. And this gives the trajectory of the definitions of quality over time, which have evolved from a very sort of academic risk-benefit assessment in 1980 with Avedis Danabedian to the WHO 88 definition, where it starts to include morbidity, disability, and malnutrition, as well as mortality, and also mentions affordability in a way. And there was a while where we were working with that affordability as a value. And then when AIDS hit, that was questioned. People like Paul Farmer and George Bush, oddly to mention those together, but they both did separate things that were useful in that regard, in terms of saying we have to treat people. We can't say that it's feasible to treat someone in Boston, but it's not feasible in Haiti. That can't be our world. Paul Farmer. And then George Bush, I think his karma ran over his dogma with what he did with PEPFAR, because he said, look, bad as things are, we can't let this scourge happen in Africa. And so I think that really mattered. PEPFAR started out with its flaws and was revised over time, and I think is viewed as an effective program that has left some models within systems that can now be expanded to other health challenges. So we get into the Institute of Medicine then, which is, important voice, talking about healthcare being safe, effective, patient-centered, timely, efficient, and equitable. And this starts to tip towards something that I think is really important, which is defining dimensions of quality. And the thing that I tell our students is we won't be quizzed on much, but you should be able to know that quality is doing the right thing right away. Do the right thing, do it right away. Everybody gets that. And that was Edwards Demings. And, just a little another Madison detail. Dr. Demings did some work in Madison in the 80s, and that's why you have Deming Way here. So we actually have some very interesting quality improvement history in Madison. So I think the dimensions of quality are really, really powerful. Because they operationalize how people can think about problems, and it allows people to think with more specificity. That is the key to improvement. And so these are the dimensions of quality that we talk about, and they align quite well with the Institute of Medicine. And I had a relatively big insight about this. It's going to sound simple, but it was a big insight in the last few years, because we did start out, this work started by taking what we called applied research or operations research, simplifying, dumbing it down, bringing internal, and so on. So we had this research mindset for what QI should be. But there's this other way of thinking about it, which is to inspire people with the idea of quality and let that bring them, to bring out what they know. And what happened when I went to India, besides all this wonderful TB work, is in talking with the nurses, what they wanted to do was not necessarily to do QI projects the way we had conceived of, with indicators and so on. They wanted to do a quality circle where every month they would sit down and talk about quality. So we sat down with all the nurses in the hospital, and we talked about how they might use these dimensions. And I said, this is too many. Pick two that you care about and talk about something you want to change. And so they picked two. They picked safety and compassion, and they decided to work on pain relief, because they didn't know that there was a norm for how often you should check on people's pain and make sure they had care. And they thought they knew how to find that information and see if they could do it. And they also wanted to work on infection control, because they could see things that were happening that shouldn't happen. And so two really worthwhile projects came out of that reflective circle, and then when they're in the circle, they share other things, and it's just getting together and saying, we're supposed to be quality people. We have this good training. What norms should we be reviewing? What can we improve? But it's very much more of a review and retraining of oneself than something like an applied research project. And we're not emphasizing the measurement in a study kind of way in the same way there. They're measuring in terms of marking things in the case record, and there's accountability, but adding that layer of making it into a little study probably wouldn't work for that setting. And this quality circle is really powerful, and it also helped them with interpersonal relations of how they would talk about things. So I thought that this idea of simple quality circles is a counterpoint and complement to the kind of thing that Dr. Aklilu would do, which, honestly is publishable if he was interested in that. And it's just two different kinds of things that can complement each other in these spaces. So we often begin with a what went right story. I'm not going to do that now, but it can be very discouraging to be in this space. And so we let people get positive energy in the room of talking about things that have gone right. And we talk about how powerful it is to envision quality. It gives people a common language. It gives them specific, measurable expectations. It also reframes deficit thinking. It's not just about solving problems. What does quality look like is a different thing than what's your problem. Saying the example of the TB is a great one. They thought they had a problem. They didn't have a medical record. What does that have to do with quality? What does the patient think? Does a patient even care if they have an electronic medical record? But when you say, what does quality look like? That's a different question, and it leads to a different answer. You get to problems, but it's different than that deficit thinking. So this needs to be grounded in evidence-based medicine as well, which we'll talk about. And, here's an example we use. We talk about what does quality look like for vaccination, and we let them work through that as a case example. And this is the kind of tool that they use. You can see how easy it would be to take that home and use it at home. We talk about evidence-based medicine. It's very important to explain what that means in a low-resource context, because a lot of people, especially if they're responsible, they misunderstand evidence-based medicine as you need to do everything the RCTs say. and it's very frustrating. It's not that they don't understand things. They don't always have the resources to follow the RCTs. So when you explain that it's a combination of scientific evidence, your clinical judgment, and the patient's values, and that there is this room there to use their judgment, then they're much more comfortable with the evidence-based model. And their suspicion is absolutely correct. And I always validate it because the studies are not done necessarily in the low and middle income countries. So it's not clear that it is translatable, and we have to correct that as a global medical community if we want people to take evidence seriously. So there's a lot of different ways of mapping the QI process. These are all different. This is the Focus PDCA one that is used in this hospital. It might have changed, but as recently as 2 years ago anyway. Six Sigma you might have heard of. You can get certified as a lean QI person. And all of these methods have a similar refrain. You define problems, you analyze them, you figure out how you'd measure change, and then you measure whether change was implemented and whether you achieved impacts, and then you go at it again. So you have this iterative thing. We decided to do something pretty linear with our model, and we have people develop an aim statement, identify a team, and then do this cause and effect analysis. And this is kind of our model. We call it the 5x5 because in the early years we find that it's hard for people to write simple reports. It's hard for people to give clear presentations. It's not what they're normally expected to do. And so we taught them how to do, and this was something that we learned from another group at UW-Madison and then applied here, but how do you give a simple presentation with 5 slides, hopefully 5 minutes, to get at the point of, what's the challenge, what's the context, what's the root causes, and what are you going to do? And so we focused on this method. One of the things we talk about in these sessions is there are some advantages into having one QI method, but in a big country like Ethiopia, with all the stuff going back and forth, you're going to have a lot of different methodologies. So I tell them the only person not to listen to is the person who thinks there's only one right way to do it, because there are a lot of people who will try to get people who are doing good work to restart it. It's very discouraging. So, if it makes sense to you, there's a lot of good ways to do QI. And there's different tools and checklists that are key parts of it, and our students learn some of these. Most of these, honestly, they've already been exposed to, so it's really having a fresh look at their value and thinking about, okay, you had a bar chart. Did anyone ever talk about what that meant in a management meeting? Did you ever decide to take action on some of the data you collected? And these are we can do that. So we're not teaching this basic math. People know this stuff. We're thinking about how to integrate that into clinical decision making. We talk about, with our leadership model, we have a fairly simple model. We use the strength-based leadership because it has some international validation. It's easy to implement, and we're busy. And also, it's positive. And when people are just coming for a week, I don't really want to do the wrong thing and get into people's personalities and stuff, where the strength-based leadership just helps you find your strengths. It's very affirming, and then you can build from that. And then people really like it. And this model has 4 categories. If you take it, I think it costs $15. It's fun. You can get classified to know, are you an executing, influencing, relationship building, or strategic thinking kind of leader? And there are words and sort of functions you have under that. So people, they take the test and they get to talk about themselves and each other and see and it's a little bit like the Myers-Briggs type thing. It has some good evidence behind it. So that we talk about that. We give examples. We also share as I said, the interprofessional collaboration model with them, which one of the key things that we take out of this is knowing how to communicate your role to a team, and knowing what scope of practice is, and understanding that there is a problem with not using your full scope of practice, with overstepping your scope of practice, which is what everybody thinks about. You're not trained to do that. And we emphasize the problem in not exercising your full scope of practice as well. Because if you're a pharmacist and you are there and there's something you know that the team knows, but the environment is intimidating for you to share what you know, you have failed just as much almost as if you've overstepped. Just as much harm could happen to patients because you were afraid to correct the leader of your team as if you administered the wrong med, right? So people have to really take responsibility for having a voice even when it's difficult with scope of practice. A system is optimized when everybody is really using their full scope of practice and not overstepping their skill set, and when everybody's scope of practice is recognized. And so, especially when there's a lot of change happening in this space, people need to know how to explain to people in their circle what they do. And I can't tell you how many times I've even been in faculty meetings where you're listening to people and you realize they don't really know about the other person's expertise. They have an idea, but no, they haven't taken the time to really share, go a little deeper with that. So and then teamwork, there's a lot of teamwork skills that come into this as well. And I think the other fun thing that we play with is the idea of an oath. Most of these people have taken an oath when they finish their training. So you take an oath together with doctors, you take an oath with a nurse or a veterinarian's there. There's a public health oath that isn't up here, but there is one. And so what I say is, have you ever thought about taking an oath together as a team at your hospital? Why don't we? This is weird. We should be doing that kind of thing. But anyway, function as if you had. And one time when we were doing the Ethiopia training and actually it was the head of the whole hospital system for the university. He went to his office and got the oath, and he led everybody in taking an oath together at the end of the meeting. And it was really powerful. I mean, there was that silence, where people were reflecting, and it's important to realize, that these commitments matter. And there is some evidence, for example, that if people are reminded of an honor code, it helps them comply. For example, I think with college students taking tests, if they're reminded of the honor code, they're less likely to cheat on the test or whatever. So anyway, oaths, I think, are another dimension of this. And we ask people to think about what promises can you make together. That's a big question for teams. We talk a lot about what it means to have a culture of quality, and that reflection on the meaning and dimensions of quality is really important. Envisioning quality is the beginning of that culture, and the idea that we can do it and it's our job. It's not an accident or a miracle when quality happens. Extraordinary measures should not be required. And in many of these settings, extraordinary measures are required to make care happen. When respirators aren't working because the electricity goes off and people are, pumping manually, or when people have to go out and scavenge around the city to get the materials they need to give care to their families. I mean, that's not a miracle, but it's crazy, right? So making sure that that the norm is quality. Leadership, I guess I'm just going to share this because it's fun to share, but I think what we've come upon in this community is competence and authority are important. We tend to focus on those, but really to be a change maker, giving and receiving trust and having and instilling hope are probably the key leadership things. If you don't believe change is possible, you're probably not going to be a big change maker. You might lead well in other ways, but and if you're not hopeful, your team isn't going to be hopeful. It is very, very hard to give trust. It's hard to be trustworthy too. Most people think they are, but it's hard to maintain hope. It's tiring. It's brutal work. So I talk about being brutally hopeful rather than naively hopeful. And in these spaces where you have young people, and just last year we had a participant from Nigeria, and he was saying, a lot of my, I could go work internationally. I want to work in my town, but the thing that was getting him down was the deaths, the medicine he knew that he couldn't practice. It wasn't because he wanted to have material things in another country like we think that is drawing everybody away. That's there sometimes, but he couldn't be the doctor he wanted to be in his space. He was feeling hopeless. And so this idea of staying there and being a beacon of hope for others, he's trying to do that. And it takes a lot of energy day in and day out. Unobserved. When you're there alone, it's different when, your international colleagues are visiting or whatever. So documenting and publishing QI efforts is another thing that we talk a lot about. I'm not going to go into a lot here. I'm going to skip. What I'm going to say is this. While we think that randomly controlled trials and that type of publication is sort of a higher form and more valuable than, these other kinds of more implementation science things. What I will say is, to my mind, they're simply different. Because if you look at an RCT, they usually don't have enough description of the intervention and change to enable someone to replicate the intervention. That's not their purpose. Their purpose is to show it worked, and then you have to write to the author to get the details. For a QI type of implementation science thing, we have some guidelines from leading voices. This is the implementation science Proctor article, which is one of the guidelines that gives specifications of how to document QI strategies in the public literature so someone can pick it up and know what was actually proved and how would I replicate it. So there are specifications of how to name it, how to define it, how to specify it, and determine the action and actor. And here's some examples. You can say, follow-up supervision calls work. Well, you need these details to know if they work. I can call, say, hey, how's it going? And hang up. That's a call. Did it work? Well, no. Turns out it needs to be a clinical expert. It needs to be a 15-minute call that's weekly for 12 weeks. And there needs to be adoption and fidelity to this protocol. So that's what we're talking about. And if you just do, if you don't specify the intervention, then it can't be replicated. And the point of publishing QI is to really clarify what works and what doesn't work, and then help it to spread through publication. So here's again a grid for that. In terms of scale up, that's a great case study that I'm not going to share now. In terms of big ideas that are on the landscape, the WHO building blocks are an important way of thinking about health system. Quality has a clear place there. We also have a movement toward task shifting that is really important globally, and more is going to happen in other countries in the U.S. because of the way interest groups work. So if there are studies that prove that task shifting does not imply less quality, we're going to be able to implement those. So QI is central to task shifting and central to translating some of those lessons to the U.S. from other places, which I think we'll have to do. And then we have human rights. Well, you know what? If you look in Article 12 of the International Covenant on Economic, Social, and Cultural Rights, and you attend to the comment that was added in 2000, comment 14, it explicates what the right to the highest attainable standard of health is. That's the WHO definition. It's very general, but here it talks about availability, accessibility, acceptability, and quality as 3 A's in a Q that are essential for realizing human rights. So when you are out there in a clinic just doing your job, recording things well, or listening to a patient, or tweaking care, you're actually doing human rights work. It's more glamorous than you thought. And people find comfort in that they're part of a big idea. And human rights can't be realized without this kind of touch point, walking it out with the details. The Sustainable Development Goals are, again, very affirming of QI. Sustainable Development Goal 3.8 is achieving universal health coverage, including financial risk protection, access to quality essential healthcare services, access to safe, effective, quality, and affordable essential meds and vaccines for all. So right there in the Sustainable Development Goals, there's a lot of them, but this one's important. In terms of future directions for in general and for us, I think in low resource settings, QI is really powerful. It's not incremental, it's dramatic improvement, and it's a great complement to system level reform in other ways. It moves the frontier of what's possible when people show a small change can be made, and everybody hears it. We didn't think we'd do that, we did that. What else is possible? So that's, we tell the students, sometimes you can't make a change you should, so you can't do everything with QI. But then you put your advocacy hat on. You say, look, I made a difference in this way. Now I'm advocating for that. And you have more power as an advocate because you're a change maker. So it really does empower you to improve governance and sustain health and well-being. In terms of our own interests, I'd like to develop this comparative systems approach to two-way partnerships. I think we can really do some interesting things here that benefit our own institutions as well as overseas. We are planning to bring some quality improvement to education in Malawi and looking at what we can learn from what we've done in healthcare in global settings to take it into education. The value of iterative cycles, teamwork, participation, measurement, all those things can be translated. There's a huge need in education. And then also thinking about what it means in urban settings. Urban science is taking shape. There's a lot of tools for interdisciplinarity there, and a lot of scale can be achieved in these urban settings. So the health sector experience with implementation science might be able to be leveraged in that space as well. It's complicated, but not that complicated. So for our QI Institute, we're going to build on our experience and the financial administrative incentives at Madison now to continue the Summer Institute in some form, to do QI capacity building, hopefully in Panama, Malawi, Ethiopia, and Nepal. We have proposals in for all of those. We don't know which ones will be funded, but a couple of them have come through as yes. We plan to develop a quality improvement online course. We just figured out how to do that this week with some resources that we have. And we want to create this ongoing learning community. We've kept a list of everybody who's participated, and we reach out to them. They do write, they do call. They're not like those ungrateful kids. So I think that we can foster some community, maybe regular webinars. And we've talked about that. In fact, last week, one participant was doing a webinar on QI. He did the class last summer, and he wrote to the whole group and said, I'm doing a webinar on QI in my country. Everybody listen in. I didn't have the right Adobe to do it from where I was, but some other people did. So there's a community building. I got another call from Tanzania. Our Global Health Certificate graduate, Adrienne White, is part of the Global Health Service Corps there. And as she looks at her role, she said, Laura, you know what? QI is going to be one of the best tools I have. I was just talking with the head of the nursing school about it. So there's a lot of ways that we might be able to expand our work. We're also looking at a possible NIH grant, some possible collaborations with USAID and the Joint Commission. Again, just putting our feelers out to try to figure out how to keep this going, how to keep it fluid, how to evolve it, and create a business model where we can strengthen our community of health science practitioners by offering this every year, and it's kind of a loose network where there's something everybody has a toe in, and it just creates community for other things we might do in the research and other kinds of global health spaces. So that's the program so far and the vision. Hopefully some stories that have piqued your interest. And, again, I've been just really grateful to be able to do this at UW-Madison with a lot of support from our Global Health Institute staff, from the School of Medicine and Public Health, Pharmacy, Nursing. They've all hosted and contributed in different ways. So we look forward to, this has been 7 years, and we look forward to 7 more. Thank you.
Okay, I think this works as well. So thank you very much, Laura. You've given us a tremendous amount to think about. I know we're kind of at the end of our time, but I think we can take a couple of questions if people have things they want to ask. And I'm going to ask you to use the mic because we are recording the presentation, so we'd like to be able to hear both the questions and the answer.
Yeah, thanks. Yeah, I had 2 points. First, I think in your list of countries, you might have left out East Timor, because I know that there have been a few.
Thank you. I'm sorry. Yes, you're right. We had a wonderful participant from East Timor. Thank you.
Sure. And my other point, I was interested in the different oaths that you've prepared. How come you're not using the Hippocratic Oath, but this other declaration of a new physician?
Well, it's a long. Those are not things that we prepared, but things that others have used. And most people don't use the Hippocratic literally. That was the most a common one that was used by medical schools. So we were just reviewing what other people are using to share. Yeah.
Thank you. Other questions? Anne, welcome back from India.
Oh, I didn't see you back there.
I just have a question, Lori, about how you do follow-up with the people that have been part of this. I mean, I think that's the big struggle, is to keep talking to people about what they're doing, because I think you miss a lot of what is happening, and how are you going to track that to know how the time that people spent in Madison is working in the places they are?
So this is a good question, and we'd obviously love to be doing more if we had, a funded program. About 4 years ago, we did an evaluation, and we got some of those stories and feedback. And more recently, we've been kind of trying to do that with this email and outreach. So, and it's not that big of a group that it would be impossible to. And some people do fall away as like they didn't do anything with it. So the people that we really want to capture, it could be that more like 30 or 35. So looking at how we would do that follow-up as part of what this NIH grant would be, because it would allow us to convene people and bring them together and do some work beforehand. But it really takes time to do that kind of follow-up. And this is all pro bono work with no grant undergirding it. Right now, we did have one grant from CDC that ran out, but that was particularly for training. So, it's like when people take a class. There may or may not be follow-up. It would be much better to have regular follow-up webinars and then the opportunity of getting technical assistance when you're ready. That would be the dream.
Other questions? Yeah.
I feel exhausted, Lori, just listening to what you've been doing. It's amazing. You said something, and maybe this is a follow-up conversation, because I didn't quite get it, but you said it's not development infrastructure that we're focusing on, and you said something about reaching down into the ministries of health. And I was trying to understand what
I
that
guess
meant.
In the development world, there's a lot of, and I don't mean to be cynical here, but there's a lot of churning of trainings. One of the easiest things you can do is show up, stay in a hotel, train 30 people, and leave, right? And so there's a lot of people who get a lot of training. There's a lot of people who get training, a lot. And then there's the next level where they don't get access to that kind of international training. So people who are working for the bilateral assistance projects, UN, USAID, the big NGOs, are more likely to get access to this kind of training. And when I've done the training at Hopkins and Harvard, those tend to be the kind of people who are there. But because we're working through our partners, people like the people that Anne brought, those people are not in those spaces, and it's often the first time they're getting this kind of opportunity. They're equally excellent, they're just in different spaces. So I value that about our program, because there's so many people doing these other kinds of things. I don't want to duplicate something that's out there. So one thing I think is a neat feature of our program is we reach people who might not have access to otherwise, and as we look at a business model, I want to keep that characteristic. Sometimes people are having fundraisers, doing homestay. They're going the extra mile to get them here. I kind of like that homegrown vibe.
Yeah, I think in the interest of time, we'll take one more question, but I'm sure Lori'd be happy to chat with you individually afterwards.
Hi there. Thanks for coming out and speaking with us tonight. I'm a first-year medical student with an interest in global health, and I was just wondering what advice you would have for people like myself in medical school or earlier in their careers on how to get involved and take place in initiatives like this.
Well, I think this is a great question. Thank you. And students like you are, a big part of our reason for being. I think that when you're a medical student, using your early experiences before you have, doing the clinical years, using your time to be in settings where you can understand the root causes of health and wellness and really get in at the community level. Even if you want to do research, it's really valuable, and life will never give you that kind of time again. So if you can spend a month or a summer just doing, learning what it's like to think about water and food and health and self-care and birth and death and, disability from a community perspective, I think that's extremely rich. I think making local to global connections, it's not all about global. It's about bringing a global context anywhere. So it's, we have ways that you could bring a global context to the kind of things that you can do. And people really love having people like you in their, working with them right here in Madison. So we talk about learning to have a global perspective, learning to have a kind of that public health holistic perspective. The most creative researchers, the most creative, are going to be starting out with those experiences. So, and you might have already done some of those kinds of things in undergrad. And if you did, we think about it as try to pick up where you left off. So you have this precious maybe month or summer. I know the curriculum's changing a bit, but you have this precious time when you're a med school student, and for the rest of your life you're going to be doing the clinical part, right? So you have this time to do that other thing. And so if you've already done something like what, say you've been a Peace Corps volunteer, or you've spent a summer, doing the kind of things I'm talking about, either looking for breadth by looking at another aspect of the system, or looking at another region would be a way to go. So say you'd been a Peace Corps volunteer in Latin America. I have great opportunities here in Latin America. It would be great for me if you went and worked there, but you probably won't learn very much. So I'd say, gee, you might want to go to Thailand, stretch yourself, think about the comparative systems approach and develop that kind of breadth. Or you might want to go to WHO and see what it's like to slog through getting, standards approved. It's not as exciting as being at the community level, but it's important to understand the system. So, trying to develop new competencies to what you have, and really it's very personalized because the medical students who come in, 10 years ago it was easy, the recipe was the same for almost everybody, but you all come in with such unique skill sets. So we'd be glad to talk with you, and you probably are already talking with Dr. Conway and Dr. Olson about things you could do. But don't miss the chance to get the global perspective, because it's to this day, those kinds of early career experiences really, I think they help me to be compassionate and be creative and remember who I am, and stuff. So
great. And yes, we'd love to talk to you about the Global Health Certificate Program and field opportunities. Notice how I slid that pitch in a recorded lecture,
get that guy
so
on a
that
plane.
It would be captured for all posterity. Okay, thanks again, everybody, for coming out. Please join me in thanking Lori. And anyone who is not currently on the Global Health Institute email list, so that you're getting announcements about all of our events that happen throughout the year, please see Kim in the back, or you can just see me, and make sure we have your email, and we'll be sure to get you on the list. So thanks again. Have a good evening.